for this opportunity that I got, and thank you, sir, for the introduction. The topic that I'll be talking on today is precision attachments. Now, this deals with the various prosthetic dilemmas that we face in our day-to-day practice and a simplified approach to solve them in a better way. Now, when the world is dealing with implants, everybody, like mostly in clinical practice, we judge a clinician by how many implants he's placed, how many all-ceramic crowns, how many full-mouth restorations he's done, how good his endodontic capabilities are. Why did I think of talking about precision attachments, which is just a modification of removable partial dentures? Now, all of us crave for one of these in our garages, right? We hope that one day we'll have one of these cars standing outside, and we also hope that the patients walking into the clinic will be proud owners of one of these, because then they'll be able to afford the expensive dental treatments that we mete out to them. We try and convince them to take up the expensive, the good high-end options, and so that they are happy, we are happy, it's mutual. But then they start telling us about the different problems, starting with the fact that either they have diabetes mellitus or any other condition for which they can't take implants, or the worst of all, sir, I don't have money. So then we step down from the high end, like in situations where there are many missing teeth, few left or almost all gone, we step down from the high end cars back to the very basics. So what about taking a middle road where you offer them something in between, something which is a modification of the very basic RPDs, but which serves almost as good as fixed teeth? Where can you use such attachments? Multiple missing teeth, distal edentulous situations, large class situations in which just a few teeth are left which can be salvaged and which can be treated endodontically and can be used to help retention of your prosthesis, or in large class 4 situations which should be treated as class 1 situations according to that old Kennedy's classification that we learned in our graduate and undergraduate days. So these are all situations which can be treated much better instead of just giving them that conventional RPD, which even in clinical practice they become irritating. The patient keeps coming back, yahan lag raha hai, wahan lag raha hai, and you just keep on going round in circles. So what are precision attachments? There is a horde of attachments available in the market, lots of them. It's impossible to talk about each one of them, and it's impractical to go into classifications and all that at a conference, because that's all theoretical. I'll just be talking about 2 situations, just to give you an insight, which you can build up on later on. One is a complete denture situation like this, in which just a few teeth are remaining. The lower 2 teeth we extracted, just the first and second premolars, lower left, and the upper anteriors, you can see it's deeply carious, grossly carious, and the OPG shows that he would have needed a lot of endodontic treatment for all the uppers, which he wasn't ready for. We convinced him to save the 2 canines, mandibular canines. We convinced him to save, go for an endodontic treatment, and then we'll progress to make him removable dentures, but better than the conventional ones. See, this is similar to the implant supported overdentures. But never is an implant a replacement of a tooth. If you can save a tooth, save a tooth. You should never extract it and plant implants. So first thing, we have to save these teeth, salvage them. You take any burr, you cut it horizontally, but about 1 or 2 millimeters above the gum level. What happens if you cut it at the level of the gum or slightly under? The gum grows over onto the tooth. You put the denture, it impinges the gums. So again, you're inviting a chronic problem. So just leave it 1 millimeter high so that the gums never come up. What you do, you better the crown root ratio by a huge proportion. You treat it endodontically, seal it off with GIC, and let him free. The attachment that we planned here is this one. This is called a PreciClix attachment. This comes from a company. There are different companies which market it by different names. I use this one. Now this is the male part which goes into the tooth, and this entire thing is the female component. Now the three colors that you see here, the white is for mild retention, the yellow is standard, and the red is for added retention. So we usually prefer using the yellow one because it tends to become very little bit loose with use. And this is the kit that you need to use. It's very simple and basic. This big thing is actually for a very small purpose. I'll show you how it's to be used. And these are the three piezo reamers. Two of them are piezo reamers, and the third one is a diamond disc. I'll show you how that is used again. This is the step. After endodontic treatment, you use the piezo reamer. There's a stopper here. So that's only till how much you need to go. Then you use the second diamond disc and you make a ditch, and you use the third one to just widen the root canal space a little bit, only enough for you to fit this inside. Okay? So we use the first step. We remove the GP up to the length that we needed. Then we use the second disc. This is what it looks like after you've used the second one. Just the amount of tooth structure that needs to be removed. It's all because it's a part of that kit. Then you use a third one and you place these two inside the mouth. Okay? Then you proceed with the normal complete denture options. You fabricate it. But when you take impressions, you see these depressions that have come onto here. Now there are two lab analogs, just like the ones that you use for your implants. And this is there. You place it, you invert and you place it inside the impression, and you pour the cast. So in your cast, you see this has come up. So when you make your denture base, you make the jaw relation records, and you do your teeth setting and try-in, that negative part, that negative depression is always there in your denture. You do the wax bite try-ins and you acrylize the denture. You can see, I don't know if you can, there are two depressions over there. The same that is, that was there because of the projection on the model. Now, anything round has to have an undercut, right? So when you do the pickup, the cold cure acrylic will go and lock into that undercut. So that that doesn't happen, there are these rubber washers. You place them, you try on the caps, see if it's fitting properly, there's no issues with them. Then with that big handle, you pick up the small one over there, you push it into the gold housing, that's called a keeper. So after 5 years of denture use, if the denture is otherwise fine, you can just drill out this yellow housing and fit a new one, which is dirt cheap. You fit it there, and then you place it in the mouth again. This will be picked up by the denture. Now they also provide these washers so that the acrylic doesn't come in contact with the tissues. But the problem with these washers is that it is very difficult to adapt it closely to the gums. So that's why I don't use it. What I do is you take your normal routine latex gloves, you make 2 punch holes in them, and you press them on. This is soft rubber. So when you use cold cure and you put your denture, it adapts to it neatly. There's no problem with it. You pick it up, you finish polish, and you give it to the patient. When the patient wears it, when he places it over the male projections, he presses it, there is an audible click, and the denture doesn't come out of the mouth. It won't come out. So he is much more satisfied than he would have been if he would have used the conventional dentures. And his pocket pinch is also much lesser had it been 2 implants or 4 implants or 5, whichever school of thought you want, and then add them up with the attachments. Okay? The next situation which I'll explain is that of a partial denture situation. Now, partial dentures all of us hate. Even the patients hate. Especially if there is going to be one clasp on this tooth, whenever he smiles, he'll be, the clasp can be, you have a metallic smile. You don't want that. So in this situation, you can see a thin, narrow bone. So implants, maybe many would have done it with advanced implant procedures, but again, convincing them, money factors, everything comes into play. So we thought of going for precision attachment supported dentures. So this tooth over here, because it's a molar, it has a good surface area. A single tooth will do. But because these are premolars with less surface area, we have to use 2 teeth for the attachments. We prepared these teeth, made vital crown preparations, and took impressions and sent it to the lab. Now this is the attachment that I would want to use here. This is called, again from the same company, this is a Preci-Sagix attachment. This is also a ball attachment in different diameters. Now you get a similar thing with a vertical line. Now that is, in that, the retention is much more, but placing and taking out the denture is a bit arduous. And the lab has to be really good, because he'll have to use a surveyor and place it absolutely parallel to each other. But with this, you have a little bit of leeway, a little bit of freedom, that even if they are not very parallel, because it's round, it can be lifted and taken out much easier as compared to that vertical line, which is called a Preci-Vertix, by the way. And this is the processing nylon housing, and this is the final housing. So we made the impressions, we sent it to the lab. When they gave us, I asked him to fit that blue part, this blue one. This is a semi-precision, because the lab will cast it and give it back to you. So you fit it onto the distal aspect of one tooth and the mesial aspect of this one. Okay? You send it to the lab again, he casts it, and you get back the metal copings with the attachment cast along with the coping. So there's no chance of it coming out, breaking, or it's not soldered. It's all in one piece. Then you ceramize. The entire thing is ceramized, only that male projection sticks out. So this male projection, now these crowns with the male projection sticking out, you replace them into the mouth, and you make another set of impressions. Don't lute the crowns. Let the crowns come out with the impression. Take it, and you refit your provisionals and send the patient back. Now you do a little bit of blocking out with your dental stone, dye stone. This is to provide space for that keeper, for that nylon housing, and a little bit of cold cure acrylic, which will fit onto the undersurface of your denture. You make the wax pattern, cast it, do all your denture steps like you always do, and you get your cast partial denture. Again, you pick up your crowns, you place them, you place the cast partial, check for fit and everything, do the same thing in the mouth. You're happy with it. Now you take your housings, you place them onto the metal projection that was there, see for its fit, and place the same thing in the mouth. This is what it looks like from the undersurface. So you see there's going to be an undercut. It is very difficult to block this little undercut inside the mouth. This is the reason that I said that do not lute the crowns. Place the crowns inside the mouth, place the denture on top of that with your cold cure acrylic resin and the nylon housings inside, and pull the whole thing out. So your crowns come out. Had you luted the crowns in the mouth, bringing it out would be a real tough job, because it's painful, it hurts the patient, so no need to go for that. You haven't luted the crowns, so the whole thing comes out easily. Once it's out, you can see it real up close and trim out just the undersurface so that the crowns come out. Once it's come out, this is what it looks like. Every time the patient fits it in the mouth, the female projections, the female parts go and seat into the male projections, and he's happy. Trust me, this is a much, much better option, which is not practiced in regular dentistry. I'm sure sir has done quite a few, but this is something anyone and everyone can do. So I would like to conclude with a couple of sayings that I picked up from Dr. Mayakar just last week. Better late than never. Everyone knows this, but never late is always better. So try it. You can try one case. It's not a hell lot of an investment, a lot of work that you have to do. Try it. And another one is, when was the last time that you did something for the first time? So any one of you who haven't done this before, try it. So thank you so much. I hope.
I thank Dr. Shounak Ghosh for the wonderful presentation. The clinical cases that he has mentioned are absolutely very, very common in our day-to-day practice. You can start practicing this particular precision as well as semi-precision attachments. They are excellent. Thank you.
Thank you, Dr. Ghosh. That was really good, precise, and very, very informative. I will now request Dr. Samiran Das to present the memento and certificate, Dr. Shounak Ghosh. Thank you. Dr. Mustafi will kindly present the certificate to Dr. Samiran Das, please. Thank you.